Not sure what happened there, but I was disconnected. My computer shut down. And then it said I had an unstable connection. So we will try this again. Let me make sure I'm plugged in here. Okay, so back to schizophrenia. We talked about hallucinations and delusions. I hope hallucinations are essentially sensory experience in the absence of sensory input, hearing voices, seeing things that aren't really there. Hearing auditory stimulation that doesn't exist, visual stimulation that doesn't exist. And delusions are strong and accurate beliefs that persist in the face of contrary evidence. I believe I'm the king of England. I've never been to England. I don't know anybody in England. My family has never been to England, so it's unlikely that I'm the king. So we'll talk about that later. So schizophrenia is defined as a pervasive type of psychosis characterized by a disturbance of thought, emotion, and behavior. So those three things. Sounds simple, but it is not. Historically, we learned about schizophrenia. We've known about this a long time. It's had different terms. It comes from, I won't even try to pronounce that, Emil Kraepelin, who had a term called dementia praecox, and it was defined. It was the first definition. It was the first time schizophrenia was given a name. And the early subtypes were catatonia, paranoia, and hepiphrenia. And so those are, we still keep two of those subtypes. And the other sort of falls under that paranoid schizophrenia, which we'll talk about later. And then there was the term, the term schizophrenia was introduced, which literally means splitting of the mind. Now, one thing that is often mistaken is using, thinking schizophrenia is related to something like dissociative identity disorder. In that way, it is not split mind. It is, you're still one mind, but your mind is essentially broken. So let's see here, skip around a touch. Psychotic behavior in some of those early days referred generally only to hallucinations and delusions, or also strange behavior, strange actions that you couldn't really explain otherwise, that accompanied some of those hallucinations and delusions. So it wasn't a very sophisticated definition, but it is oddly pretty similar to where we are today. Here's one of the things about disorders. We don't know a lot more about schizophrenia than we knew 10 years ago, 15 years ago, 20 years ago. A lot of disorders, research sort of dies out. There's not a lot of new information that comes up, and schizophrenia is really one of those. Occasionally you'll get new medications that are just variants on old medications, but we're not getting a lot of new material or research in terms of schizophrenia or how to treat it. So a lot of the information we have had for a long time. There have been some studies on genetics and things like that, looking at gene combinations that might relate to schizophrenia, and that was kind of cool, but it didn't really get us anywhere in terms of treatment or give us a lot of productive information to really deal with. So the DSM categorizes schizophrenia, or it defines schizophrenia according to some criteria, which I will kind of go over with you here. Two or more of the following present for a significant period of time for 1 month. And it's a shorter duration than some of the other disorders. Part of that is because it is so severe in nature. So you don't need a lot of time with the symptom to know something's unusual. It takes a long time with symptoms of depression in order to be able to get a diagnosis. It takes, well, depression's kind of a bad example. Like bipolar disorder. You want a little bit longer course of symptoms. With something like generalized anxiety disorder, you want a longer period of time for symptoms. But with schizophrenia, you know pretty quickly that something is abnormal. And often there's a caveat with this. It's 1 month or a hospitalization that interrupts that period. So symptoms that are identified quicker than 1 month um, because you're hospitalized would immediately qualify you for those diagnoses. So 2 or more of the following for 1 month or until hospitalized, like I said: delusions, hallucinations, disorganized speech, just frequent derailment of thought. So you start talking, you jump around a lot, you don't have a clear flow of your speech, you don't come back to finish your topic. So I'm talking about trucks, and then I jump over and I talk about football and never come back to finish my idea on trucks. Then I start talking about coffee, and then schizophrenia, and then bipolar disorder is sort of this tangential, incoherent line of thought. It's hard to follow. We've all talked to people who just kind of jump around a lot and have trouble staying focused. This is different than that. It just doesn't make sense. You can't tie it all together. It's not even loosely related. Often it sounds just like random words. Grossly disorganized or catatonic behavior. Again, catatonia is one of the original subtypes. And catatonia is essentially a condition where you have a lack of movement, or you just sort of are frozen. You stand still in one position, you lay in one position, you don't really respond to other people. So that is essentially what we mean when we talk about catatonia. We'll go over that a little bit later, just a little bit, but that's the long and the short of it. Disorganized behavior. This is more similar to what we see sometimes with disorders like ADHD, but in a grander scale. Just doing a lot of things that aren't productive, that don't make a lot of sense. With ADHD, it's just kind of a lack of focus. But with this, it's just there's no focus, but it's also just sort of random. Like I start a project, I jump around, I go do something else. None of my behavior makes any sense. None of my presentation really makes any sense. I'm just really, really disorganized beyond what you would expect from some of the other disorders. Sort of an exaggerated version of some of those other things. And then negative emotions, like lack of emotion, no emotional expression. When you should be happy, you just have this flat affect. In other words, no emotion. Or lack of energy, just inability to move, lack of interest in doing anything productive. And for a significant portion of the time since the onset of those symptoms, levels of functioning are impaired in work, personal relationships, self-care, all of that sort of thing. And continuous signs of disturbance. So remember, you have to have presence of symptoms for a month, but then you have continuous signs of disturbance lasting for at least 6 months. So you have to have a month of active symptoms and then like 6 months of ongoing symptoms. But like I said, that can be short cycled too by presentation to a psychiatric hospital or some sort of legal issue that relates to your disorder. That will speed up your diagnoses. And other disorders that are similar or ruled out: schizoaffective disorder, which we'll talk about in a minute, or depressive disorder, bipolar disorder with psychotic features. We didn't really touch on that, but a lot of the mood disorders have, in extreme cases, some symptoms that are similar to schizophrenia and often are misdiagnosed. May have some delusional thoughts or some paranoia that come along with that. So you've ruled out those other disorders because this is the more extreme disorder, so you want to rule out other things first. And also we know that it's not due to a medical condition like dementia or Alzheimer's. It's not due to being under the influence of drugs or alcohol or withdrawing from those things. And it is not related to an autistic disorder. And if you've had a history of those disorders, the diagnosis of schizophrenia can still be made in addition, if you have delusions and hallucinations, in addition to the symptoms of autism. I've mentioned it before, and I'll talk a little bit about it tonight and next week, but the autism and schizophrenia have a lot of common symptoms, and probably some people who are diagnosed with schizophrenia were probably misdiagnosed. They probably should have been diagnosed with autism, and I've certainly seen some of those in my day that now looking back kind of fit better with that, with the autism diagnosis, but very similar. Also very similar neurologically, and we'll talk some about that when we talk about autism. Autism's the exact opposite of schizophrenia. We have tons of research on it, and it's constantly ongoing. and primarily because it affects children instead of older adults, and that does make a difference. There's a lot more push to do studies on new disorders, but there's even more push to do studies and research on disorders that affect children. So schizophrenia is generally made up of positive symptoms, negative symptoms, and then sort of other symptoms that we'll talk about. But positive symptoms are not good. Negative symptoms are not necessarily bad. Positive just refers to the presence of visible symptoms, active manifestations of abnormal behavior, sort of things that you can see. Negative symptoms is some of that lack of motivation, not wanting to do things, flat affect. So the absence of visible symptoms, sort of, would be a good way to describe it. So one of the positive symptoms that we see the most often is delusions, which is, again, a gross misinterpretation of reality. And the most common are delusions of grandeur, thinking you're similar to like narcissistic personality disorder, thinking you're have this inflated sense of importance, but here it's completely illogical and unreasonable. Thinking you are God, or you are, like I said earlier, the King of England, or this extremely important figure who others defer to, with no real evidence of that. And then one of the other common delusions is delusions of persecution, feeling that people are out to get you or trying to hurt you. All of this sort of negative symptom, symptoms that come on and often lead to fear, paranoia, and that sort of thing. Hallucinations are also a positive symptom. Again, not good, just the presence of something that we can see. You experience sensory events without environmental input. I see things that are not actually audible to other people or should not be audible to me. There's no evidence of being able to hear things in your brain. No sensory input in your visual cortex that will lead you to actually see something, but you do. Now, interestingly enough, in brain scans, sometimes some of those areas of the brain are activated. So there is this real experience of seeing or hearing something. So it isn't that it isn't real in the sense that they're not experiencing it, because they are experiencing it, but there is no input that would cause anyone else without the disorder to see or hear those particular things. We talked about that other stuff. A lot of this has to do with impairments in different areas of the brain, activation in different areas of the brain. And a lot of those are functioning in the cerebral cortex, like the Broca's area, which controls speech, the Wernicke's area, which controls hearing, and your visual cortex. So again, seeing, hearing, those parts of the brain that are involved with that are implicated in schizophrenia. So damage to those particular areas can cause some kind of ongoing impairment. So negative symptoms are the absence of normal behavior, or insufficient normal behavior. Your behavior is abnormal. Avolition or apathy, lack of initiation or persistence, the absence of speech. So a person with negative symptoms of schizophrenia may be very quiet, not talk a lot, not be very responsive. Anhedonia, which is lack of pleasure or indifference, similar to that as someone with severe depression. They just don't have any interest or a lot of interest. And the flat affect, no emotional expression, or emotional expression that doesn't match the emotion, laughing when they're sad, or crying when they're happy, and not in the way that you sometimes cry when you're happy, but like a completely inappropriate response. And then the disorganized group of symptoms, confused or abnormal speech falls under that, confused, dysregulated emotions, illogical, incoherent speech, word salad, just random words that don't fit together. The sentences don't make any sense. You go off on tangents. You jump around from one subject to the other, or they're loose associations. So the conversation is just all over the place, and it doesn't really make a lot of sense. It's very hard to follow. Talked about some of these other things. Catatonia falls under this category of a disorganized symptom. And it can be sort of its own category of disorder, but it can also be a symptom of other types of schizophrenia. There used to be DSM-4 all the way back. There were all these subtypes: paranoid type, catatonic type, residual type. All of these were types of symptoms that were linked to schizophrenia. So if you had a paranoid type schizophrenia, your primary symptom was paranoia, in addition to hallucinations and delusions, which have to be present in order to get the diagnosis. But you also had the presence of paranoid thoughts, where you thought people are out to get you or trying to hurt you. Those delusions of persecution I was talking about earlier sort of fall under that. But we, as we moved into the DSM-5, we eliminated those subtypes. They're still part of the descriptor, so I would still describe it as being schizophrenia with paranoia, but it's not a specific type. Just sort of a change in terminology, with the understanding that a lot of people have paranoid symptoms. A lot of people have catatonic symptoms at different points. And so it was just sort of it didn't necessarily mean what we thought it would mean. So those descriptors were taken out. So some other disorders that are similar to schizophrenia and sort of on that same spectrum: schizophreniform disorder. These are psychotic symptoms lasting between 1 and 6 months. So it's like a short-term diagnosis. If you have someone new to your office who is just now experiencing their first psychotic symptoms, or you see somebody in the hospital and it's the first time they've ever come to you with like schizophrenia, you may diagnose with schizophreniform just because you want longer period of time in order to be able to see and judge whether or not they have active symptoms of schizophrenia. Brief psychotic disorder, which is symptoms that are lasting less than a month. And often with brief psychotic disorder, they are not recurrent. Schizophrenia, this is a lifelong disorder. Generally, schizophrenia starts after the age of 18, usually somewhere between like 18 and 25, 26 years old, before you're 30. With brief psychotic, and it continues on well after that throughout the rest of your life. With a brief psychotic disorder, it may be a response to something like tremendous anxiety or serious trauma, but it's sort of a one-off thing, or just happens a couple of times and then you're perfectly okay. So it isn't that you're living with this disorder. You just happen to have a psychotic episode that isn't really well explained by anything else. Like, it wasn't because you used too many drugs. It wasn't because you were withdrawing from drugs or you had some sort of acute medical issue. You had this episode, we can't really explain why. But the two of those disorders have relatively good functioning compared to the other disorder. And with brief psychotic episode in particular, most people will regain a normal life and don't go on to develop any other sort of long-term psychotic illness. So schizophreniform, the DSM, 2 or more of the following are present for 1 month: delusions, hallucinations, disorganized speech, catatonic behavior, negative symptoms, those sorts of things. But they require you to last less than 6 months. So if it goes on past 6 months, then you have to diagnose schizophrenia. Let's see. I did something here with my notes. Let me fix that. Okay. Schizoaffective disorder is another disorder that is related. Probably don't want to sit here. I'm moving a lot. Schizoaffective disorder is similar to like depression with psychotic features or bipolar disorder with psychotic features. It has a mood disorder component, but the psychotic symptoms are sort of the primary focus, as opposed to depression or bipolar disorder with psychotic features, when the mood disorder would be the primary problem. So schizoaffective disorder symptoms of schizophrenia plus a major mood disorder, depression, or mania. The psychotic symptoms must also occur outside of the mood disorder. So if they only occur when you're depressed or when you're manic, then it is the other disorder. The psychotic symptoms can't be in addition to. They are the thing that is present all of the time. And these people, unlike people with depression, don't generally get better on their own. So they generally are going to require more treatment, similar to that of people with schizophrenia. Let's see. Delusional disorder is another disorder that falls under the psychotic disorder category. Delusions are a part of schizophrenia, but you can have a delusional disorder outside of it. You can have a delusional disorder on your own. And so delusions, again, are contrary to reality, and they can have many forms. Some of the ones your book talks about are erotomantic, feeling that someone's like in love with you. Often this is like celebrities or people you see on TV. You see all of the time, like celebrities who are getting stalked by people who are, psychotic. And oftentimes it's these sort of delusional disorders where they feel like they'll tell you that I thought that person was in love with me, and they have this special connection. And often they're sending me messages through the TV communicating their love to me. And so that falls under that category, erotomanic, I cannot say that word for anything, erotomanic delusions. Grandiose delusions, again, we talked about earlier, feeling like you are this superior person, like a god or like a king or something of serious importance. Jealous delusions, this pops up in relationships where you feel like the other person is, you're always wondering what they're doing, checking their phone, think they're cheating on you without any real evidence, and even with evidence to the contrary. Persecutory delusions, feeling that people are out to get you, trying to make you look bad. And then somatic delusions. I've seen some folks with somatic delusions before, and they may experience this thought that they're always like going to die or always have something wrong with them, even in absence of reality. So they go to the doctor and they say, you don't have a tumor. I did a brain scan, but they genuinely believe that they do. It's pretty rare, but the prognosis is better than it is with schizophrenia. Catatonia, I'll go back to that. It can be a type of disorder or a symptom presentation on its own. It's often part of schizophrenia. Unusual motor responses, particularly immobility, not moving, or can also be agitation or really odd mannerisms. And it tends to be severe. It is pretty rare. These days it's pretty rare. It has been more common in the past, but it's pretty rare these days because medications tend to be very effective, although not the medications that you would think of. Medications like antipsychotics often don't work on this, but things like benzodiazepines are very, very effective in treating catatonia. So we're able to identify it and then pretty quickly treat that. And it may include things like mutism, not talking, maintaining the pose for several hours, standing or lying down. The opposition or lack of response to instruction, repetitive or meaningless behaviors, mimicking other people's speech, all part of catatonia. And then you can have psychosis because of other causes. Psychosis can occur because of substance use, medications, or any other potential cause. But you can't treat this type of psychosis unless you can get to the underlying cause. Let me pause that. Somebody's knocking on my door. Hold on. Yes. I can't right now. I'm going to do another lecture. I'm presenting a lecture, but I'll come up there like as soon as I finish. Okay. Yeah. Okay. 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 Thank you. No, no, you're fine. All right. Sorry about that. I live next door to a recovery house, and I also work in the recovery business. So sometimes they come to get me to intervene. So I told them I'd come over when I finish. The psychotic disorder, due to other causes like substance use, medications, other medical conditions. So if I have a substance or a psychotic disorder that is due to Alzheimer's disorder or dementia, I have to, if I know that that's the cause, I can treat it. If I have psychosis that is due to being intoxicated, I know how to better treat it. So the treatment is shaped by the particular disorder. Let's see. Let's skip ahead a little bit there. So just some of the facts on schizophrenia. I said earlier, it affects about 1% of the population, often develops in early adulthood, and can kind of pop up at any time. Childhood cases are rare. Honestly, they're probably misdiagnosed. They were probably diagnosed as misdiagnosed autism cases. It's not unheard of that you can have a child with schizophrenia, but it is rare. It is chronic. Most people have severe, moderate to severe lifetime impairment. It really gets in the way. It's really problematic. Life expectancy is less than normal people. So there's a higher risk for suicide, higher risk for like accidents, and generally people don't take care of themselves. Another factor in why life expectancy is so low is that there are medications that have a lot of side effects. A lot of antipsychotic medications can cause problems with diabetes, high blood pressure, things like that. So they can decrease the life expectancy by causing other medical conditions. And also people with schizophrenia don't often have the best health care. They may not take care of themselves. They're probably not going to the doctor. They may be suspicious of the doctor. So that all plays a role there. It affects men and women about equally, but women tend to have a better prognosis. And the onset is generally earlier for men. I don't know why for either of those things. Schizophrenia happens in every culture, but it isn't always viewed the same. In our culture, we generally, folks with schizophrenia rarely have great relationships with their family. Other cultures tend to take them into the family, less institutionalization, less trying to hospitalize or medicate the symptoms away. They just sort of take them in and are more accepting. We generally try to medicate, again, have poor relationships with the family. There's a lot of expectations put on some of these people that they can't really meet. It does run in families, very genetically heritable. So heritability index is like the amount of genetic relationship, and it's about 46%, 50% for schizophrenia. So there's a good chance, half chance, that if you have two parents with schizophrenia, you're going to have schizophrenia. There's a strong genetic link. So the closer you are to someone who has schizophrenia, the more chance you are to also have schizophrenia. Identical twin with schizophrenia, you have 50% chance of having it if that twin has it, but it's only 50%. So there must be other components too. There are environmental components as well, or other factors. Some of the research here, do twin studies, monozygotic twins, identical twins versus fraternal dizygotic twins. There was a greater risk if your identical twin had schizophrenia, which supports the gene or role of genetics. Less of a chance, same chances, any other sibling. If you just had a sibling with roughly a 25% chance. And it was the same for dizygotic twins. So as opposed to 50% with monozygotic. So that does suggest a high genetic component. Adoption studies found that, so you're looking at the genetic link with a different environmental makeup. So the adoptee risk for developing schizophrenia remains high if there is a biological parent that has schizophrenia. So again, there is this genetic risk, but it's lower than for children raised by their biological parents with schizophrenia. So it also shows that having a healthy environment is protective against your genetic makeup. So if you have two twins, or if you have a child who has a genetic makeup of having a 50% risk for schizophrenia, they're raised by biological parents who are schizophrenic, there's a higher likelihood they're going to express symptoms of schizophrenia than if that child was taken away and raised by someone who was who did not have schizophrenia. So strong genetic link. And I mentioned earlier there were a lot of gene studies a few years ago that looked for genetic combinations related to schizophrenia, with the idea that you could just sort of come in and turn off those genes. And you know, that's still sort of a bit of ongoing research, even though it is not. If we ever find good genetic information, you could do some things with treatment like turning off genes, but that seems so far away right now, even as much as we know about genetic information. So some of the causes of schizophrenia, we have the dopamine hypothesis, which suggests that schizophrenia is related to overactive dopamine, so too much dopamine in the body. And the reason for that is drugs that increase dopamine result in schizophrenic-like behavior in people who are not schizophrenic. So people with like dementia, who take Parkinson's disease, who take drugs that increase dopamine, have side effects that make them look like they are schizophrenic, but it's due to the medications. So we sort of get there backwards, but it is interesting. And also drugs that decrease dopamine, like you give people who have schizophrenia, reduce schizophrenic-like behavior. So but the problem is that's probably oversimplistic, and other neurotransmitters are involved. We now think that not only dopamine, but some of the other transmitters as well, serotonin, norepinephrine, pretty much all of them are implicated here. So it's much more complicated than just say dopamine is the cause of schizophrenia. Some of the brain studies you see, like enlarged ventricles and reduced tissue volume. So it is definitely a neurological disorder, and it has a neurological impact on the brain. And there's less activity in the frontal lobe of the brain, which is also interesting because that is a major dopamine pathway in the brain. That's where most of the dopamine is created in your brain, is that frontal lobe, and there is less activity there. So that, again, kind of supports the importance of dopamine. Also some findings that looked at viruses prenatally, but you'll find those similar findings with a lot of disorders, with autism, certainly with ADHD, finding that infection early on in pregnancy can cause a greater likelihood for schizophrenia, but also a lot of other mental disorders and physical disorders. Some of the other things that may cause it, marijuana use can increase the risk of developing schizophrenia, in particular people who already have the genetic makeup to have schizophrenia. Marijuana isn't going to cause you to be schizophrenic if you don't have the genes that increase your risk. Let's see. Stress may play a role. There is certainly evidence to suggest that stress may activate the vulnerability. We talked about earlier about this diathesis stress model, this stressors in your life that increase the likelihood if you already have the genetic predisposition to reach this disorder. So stress is sort of the trigger. It activates the disorder when maybe if you didn't have exposure to that stressor, you would never experience the disorder. Stressors can also increase the risk of exaggerated symptoms or more symptoms when you already have the disorder. One of these slides talking about diets is a stress model. What a surprise. In terms of treatment, we have a lot of medical treatments. It was really the first, prior to sort of 1950s, when people had schizophrenia, we just put them in institutions. We put them in psychiatric hospitals, lunatic asylums, as they were called. And we locked them up until they died. And there was no real treatment. Things like lobotomies, drilling a hole in their head, and some of the things that we talked about at the beginning of class, some of those very rudimentary treatments. In the 1950s, we started to find some medications like Thorazine and Haldol that came along that were very effective in treating some of the symptoms of schizophrenia for the very first time. And those medications sort of led the way into pursuing other medications. And the first medications had a lot of side effects. They had, they reduced symptoms like delusions and hallucinations. They were much more effective with the positive symptoms, but they caused a lot of very serious side effects, the Parkinson's-like side effects. The Thorazine shuffle, you've probably heard of that. Thorazine was probably one of the most common antipsychotic drugs, and it was given a lot in psychiatric hospitals, and it had a lot of side effects, the Thorazine shuffle. So which is something similar to what you see, like the rigid muscle movements that you see with Parkinsonian patients. Also tardive dyskinesia, some weird like muscle rigidity that will result in things like, you know, like your head being stuck in one position because your muscles here would tighten up, or like tongue tremors or other kind of odd side effects that came along that could be really serious. Compliance was a problem. Because the medications had a lot of side effects and they didn't particularly make you feel good. So there was a huge issue with people not taking medications like you're supposed to. And then some of the psychosocial treatments. Historically, we used like token economy programs and inpatient psych units. I remember when I first started in this field and worked in this personal care home, we used to give people points for washing their hands or for taking a shower. So it's a token economy program. We're trying to encourage pro-social behavior that is beneficial to the person and that they're not likely to do on their own by giving them something. And so they could trade in these points for cigarettes or for candy or drinks or whatever. Probably wouldn't fly today to give people cigarettes for washing their hands and taking showers, but we did that. For going to groups. So you're giving them something to encourage. We do this a lot in schools. I give you a token. I give you something in exchange for, give you check marks if you do something good. We use a lot of social skills trainings, teaching people how to get along with other people, particularly other people who are suffering from the same disorder as them, but also people in the community. How to live, doing life skills training. How do I do laundry? How do I clean and cook? Remember, this is a disorder that starts in like when you're 18 or 20 years old. And so a lot of people never really learn those basic life skills that we learn at that point. Working with families, doing behavioral therapy is also very important. And then things like vocational rehab, doing job training, working with people and identifying job skills that they can do even with their disorder to kind of help them be successful and have other things in their life that are reinforcing. So I think that's pretty much all I want to talk about with schizophrenia. I will post some videos. I mentioned those in that first part of this video that got cut off, but a couple of videos about a former client of mine whose family posted these videos several years ago. It's like a training education. I think they're very useful, so I will put them up at some point throughout the week. I will also put up a couple of other things that you might be interested in. If you want to watch a movie with somebody who has schizophrenia or about someone with schizophrenia, Beautiful Mind with John Nash is very good and does a pretty good job depicting it. It's kind of controversial in some ways because they discourage or they promote not taking medications, kind of, I guess. It was his story, so it's not really encouraging anything if you ask me, but it can be seen as being encouraging behavior that isn't positive for most people. John Nash is a Nobel Prize winner. He's not most people. But it's a very good movie. So Beautiful Mind, John Nash. It was a book too, if you prefer to read, but it's very good. And I would encourage you to watch it. There isn't a lot of good, accurate depiction of schizophrenia in movies. Usually it's people are bad guys and villains, and you know, it's like this exaggerated extreme version. Not good at all. I mentioned earlier in the semester and posted a link to the Rocky Erickson documentary. He's another individual with schizophrenia who ended up being fairly successful, probably not as successful as he'd have been if he didn't have schizophrenia, but nonetheless, watch that if you are interested. But it's a very interesting subject, and I hope you will spend some time looking at the videos and thinking about what it would be like if you had a life where you couldn't trust your own instincts, you couldn't trust what you saw or what you heard, where your senses sort of defy reality. And you just can't trust them. It would be very hard to live a life like that. So hope you'll give some time and just sort of think that over, because I think it's important when we're talking about this. So hope you have a good week, and I will see you again next week.